All right, we will go ahead and get started. First, I'd like to thank everyone for joining us tonight on this final installment of our Journal Club webinar, which is brought to us by an unrestricted grant with Medtronic. I'd like to introduce the expert panel that we have here today. So we have Dr. Bo Yang, who is an associate professor in the Department of Cardiac Surgery at the University of Michigan. We have Dr. Leonard Girardi, who is a professor and chair of cardiothoracic surgery at the New York Presbyterian and Weill Cornell Medical Center. We have Dr. Maral Ouzounian, who is a cardiac surgeon at the Peter Munk Cardiac Center and associate professor of surgery at the University of Toronto. And we have Dr. Joseph Bavaria, who is a professor of surgery and vice chief in the Division of Cardiovascular Surgery at the University of Pennsylvania and the 52nd president of STS. We also have Dr. Tsuyoshi Kaneko, who I believe may be joining us just a little bit late. I believe he is currently finishing a case and may be joining us promptly afterwards. I'd like to also introduce the trainees. We have Dr. Irbaz Hameed, who is an integrated CT surgery resident at Yale and a TSRA executive committee member. We have Dr. Samir Hirji, who is a cardiac surgery resident in the 4-3 joint program at Brigham and Women's Hospital and also a TSRA executive committee member. And we have myself. I am Clauden Lewis. I am a PGY6 integrated cardiothoracic surgery chief resident at the University of Rochester, and I am the current president of the Thoracic Surgery Resident Association. Today we'll be discussing the treatment of type A dissection. We'll be having a discussion on open and endovascular modalities. We thought to discuss these two potential strategies for management of with or without malperfusion syndromes. We discussed two interesting papers as a foundation for discussion, given their unique approaches. This discussion may help us understand various strategies. I'll ask Irbaz to continue on, and we'll start with the first paper.
Thanks, Clauden, and thank you everyone again for joining us this Thursday evening. The first paper that I will be presenting today to set the tone for today's discussion is on endovascular fenestration stenting prior to delayed open aortic repair for type A dissection. This is a study by the Michigan group led by Dr. Bo Yang and colleagues. And this is the abstract of that study. Briefly, what they did was over a period of 10 years from 1996 to 2017, they looked at 597 patients with acute type A aortic dissection. 135 patients had malperfusion syndrome and were treated with upfront endovascular reperfusion followed by delayed open repair. They compared the outcomes between the first and second decades for these patients and compared the observed mortality with the reported outcomes for upfront open repair strategy for every patient using some prognostic models. Their findings are summarized on this slide. Briefly, what they found was in-hospital mortality improved between the two decades. It was 21% versus 10.7%. It was significantly less than 0.001. In the second decade, for patients with malperfusion syndrome who were initially treated with fenestration stenting, mortality from aortic rupture decreased from 16% to 4%. The p-value for this was 0.05, which is borderline significant. The risk of dying from organ failure was 6.6 times higher than dying from aortic rupture, with a hazard ratio of 6.63. The confidence interval was 1.5 to 29. 30-day mortality after open repair for malperfusion syndrome patients was 3.7%. Compared to expected mortalities with upfront open repair for every patient, their observed 30-day and in-hospital mortalities were 9% and 11% respectively. And this was significantly lower, P0.03. And they concluded in this paper on circulation that immediate open repair is the strategy to prevent death from aortic rupture for majority of patients with acute type A aortic dissection. However, for relatively stable patients with no rupture or tamponade, patients with malperfusion syndrome benefit from a staged approach with endovascular management first, followed by eventual aortic open surgery, open repair, following resolution of organ failure. This is a brief summary of this paper by Dr. Boyang. So I will ask Dr. Boyang first to please comment on this paper and give us some insight into how this approach emerged at Michigan and what was the thought process in this practice shift from open repair for everyone versus endovascular first, followed by delayed aortic repair.
Yeah, thank you for the nice presentation. It's a nice summary of our study. This idea actually started about more than 20 years ago by Dr. Michael Deep and Dr. David Williams. Dr. David Williams is an interventional radiologist. I remember they told me they were in a like family party or something, holiday for a week. And the Dr. Deep said, I have those patients who come in and with dead bowels, malperfusion, dead guts, and we operate on them, they just die. And it's just such a high mortality for this disease. And Dr. Williams said, oh, I may have a solution. So he started thinking about using endovascular to resolve the malperfusion first. And once it started, and the first paper I studied was presented by Dr. Deeb at the aortic symposium was 20, 30 years ago. Everybody got so mad at him. And the surgeon said that you are just immoral, you let patients rupture and die. And so that's not well accepted at all at that time. And Dr. Deeb and Dr. Williams continued this approach. And then Dr. Patel joined the group as a new surgeon and continued. And 10 years later, and Dr. Patel presented the data again. And still, they found out that we still have, as you can see, that decade, we still had about 16% rupture rate. And those patients always get criticized, patients, if we don't do open repair and the patients rupture and will die, we could have saved those patients. So when I came to Michigan, I was trained at Stanford, and our approach, just like most centers at Stanford, and just operate on everybody. And I remember when I was a fellow, and there was a surgeon did the type A dissection, and at Camilo, another site night, the hospital of Stanford presented the M&A, and they did a acute type A dissection repair. During the operation, patient just becomes so acidotic and hypotensive. And when they finished the operation, the patient just barely alive. They opened the abdomen, the gut was completely dead. So that's an inch of death. So I came here, and Dr. Deeb and Dr. Patel started teaching me this, because when we started doing this, I was worried about rupture. Every surgeon was worried about type A rupture. And there's a couple of things in this approach is it's the judgment, who should go to the OR immediately, who can benefit from this approach. The definition, the patient we choose to go to the IR is not malperfusion per se, it's called malperfusion syndrome. So people always ask, what's the difference? Malperfusion syndrome. And I remember Eric Osaldi asked in the meetings, I cannot tell the difference. And what's the difference of that? So I've been thinking about the difference between malperfusion syndrome and malperfusion. And one time at dinner, and my teenage daughter was asking me, the dad, what's the difference between HIV and AIDS? That triggered me. I immediately thought about the the analogy about malperfusion syndrome. There are a lot of analogies, bacteremia and sepsis, and the septic shock. Malperfusion is the abnormal flow to the end organ, the inadequate flow. Malperfusion syndrome is a consequence of that impaired flow to the end organ, causing organ damage, death, and dysfunction. If it can be early, like early sepsis or late sepsis. The early stage, the dysfunction or necrosis not that severe. We can resolve, resolve malperfusion. Patients can recover okay. The late stage, patient with dead leg, dead guts, those patients that go to the OR, most likely they will die. No matter what you do, they will die. The acidotic pH 6.86, 7. So acidotic, those patients would die. So that's I learning that from them, and I started to using this approach. And thanks God we have Dr. Williams to help us doing this and to open the vessel first to perfuse end organ. And the most of patients, they have malperfusion syndrome, and they have organ dysfunction and the necrosis. Sometimes it could be transmural, like dead guts. We open the vessel, open the SMA, then call general surgery. General surgery taking them to the OR, do a bowel resection, and second look, wait for patient to really resolve ARDS and acidosis, everything. Then we operate those patients. After the malperfusion syndrome, the organ failure resolved, and the operative mortality actually is just as low as a patient without malperfusion, never had a malperfusion. Those patients who died after we resolved the malperfusion, they still have multi-organ failure, they died. No matter what we do, we can operate on those patients, resolve malperfusion, they still die from organ failure. In the second decade, we only had like 4%, 2 patients died of rupture. That's because we got more experience with medical management, such as really aggressive control the blood pressure, and keep patients sedated, and watch them very closely. The ICUs, our ICU is very comfortable to take care of type A dissection patients medically. They don't get nervous. They have type A dissection patients sitting in the ICU and for 1 or 2 weeks, just waiting for the organ function to resolve. I currently have one, actually. He had the dynamic malperfusion, completely occluded the SMA celiac, right renal, and the right iliac artery. We did the fenestration and the stenting. He immediately got ARDS because all the reperfusion, ischemic reperfusion injury, renal failure, it's immediate. He was on vent for like 10 days now. Think about operating those patients, how sick they will get. And he did a rupture, and we control the blood pressure very aggressively. And if we need to activate those patients, we really do it very smoothly, try not to get a surge of the blood pressure. That's the story, the version of how I learned here as an outsider from another institution coming to Michigan.
Thank you, Dr. Yang. Dr. Girardi, what are your thoughts on this approach, and what is the management of patients with type A dissection in your practice with and without malperfusion?
So I think, I think Dr. Yang and the group at Michigan have done an incredible job of sort of pushing and pushing the envelope significantly in this area where the mortality for these patients, no matter which approach you take, is very high. And I think in addition to great results in improving the outcomes for a subset of these patients, I think it's really stimulated the discussion and kept a lot of us thinking of alternative ways to take care of these really sort of critically ill people from the minute they hit the door. So I think there's a couple of points in what Dr. Yang spoke about that I think are worth clarifying. And that's number one, this is for a subset of patients that have a malperfusion syndrome, not just mechanical malperfusion. If they have reasonable acid base, if they're not profoundly hemodynamically compromised from acidosis, et cetera, an open repair is still a reasonable way to go. But for patients who are with advanced acidosis, high lactates, et cetera, in shock, I think this is a good approach. And the other thing that I think is worth mentioning is he mentioned that the dramatic improvement in the medical management of type A dissections, which markedly reduced the mortality in their experience. And I think that's crucial to all type A's while they're getting ready to go to the operating room, whether they're being transferred or whether, you know, whatever, maybe there's a delay in the OR for whatever reason. You know, if you drop their pressure and beta block them, you can really keep things going for a while. So I think that's critical points. For patients who sort of have malperfusion, but not the syndrome, our preference is still primary repair. And then for the most part, those patients do pretty well. Although, as he said, you have to have a high index of suspicion for bowel ischemia, laparotomies, bowel resections, second look laparotomies. It's a process for sure. But I think with attention to detail and a real sort of patient selection for this type of approach, you can get better results using both techniques.
So I'll ask like the third question here. Dr. Ouzounian, how is this approach, or what are your thoughts on this paper? And also, how is it different in Toronto? And what are some of the strategies that you guys utilize at your institution?
Thanks, Amir. I think I echo what Len has said. The Michigan group has really been, they're the pioneers of this approach to going after malperfusion syndrome with a malperfusion operation before the central aortic operation. We do it as well. We do it more with TVAR plus or minus dissection stents distally rather than fenestration. We've just had better success on an endovascular side with dissection stents to open the true lumen distally, but we're pretty selective. Like we will do that if there's really, you know, the LFTs are up, the lactate's really high, there's a really active visceral mesenteric ischemia. If the patient just has radiographic malperfusion or the lactates in the, you know, below, you know, still in the, you know, 3-4 range, and it's a radiographic finding, we prefer to do a central operation, even if there's radiographic malperfusion of all of the, you know, the viscerals, the kidneys, and so on. But in that setting, we tend to favor something more aggressive in the arch, an extended arch repair in the setting of malperfusion. So, you know, the three options that we use are the uncovered AMDS stent, which is can be deployed in zone 0, and it's an uncovered stent that goes across the arch. It's a hemiarch and a zone 0 repair. It's a very easy repair, and it's very good for malperfusion. 96% of vessels that are thrombosed will open up on the post-op imaging with that. Our other option in a young patient with a tear in the arch or a distal tear with a retrograde dissection, we do the whole thing. We do a Thoraflex repair, usually some kind of total arch frozen elephant trunk with a stent in the descending aorta. And we were doing quite a bit of antegrade TVAR for malperfusion, but we're sort of moving away from that right now. So those are the three things when we do a proximal repair in the setting of malperfusion. But I would say one other thing to be mindful of is these patients, as Len said as well, you need a high index of suspicion, and they need early imaging to see what your result is. If you come out of the operation, their femoral pulses are back, they're peeing buckets, you know, their lactate's coming down, okay, fine. But for anyone who's, you know, potentially compromised, if you have a hybrid OR, great, you can do angiography on them, or just take them to the CT scanner and actually look anatomically. It's better to have a little hit of dye to the kidneys and know what the distal malperfusion situation is from, because this is what they die from, people who come with malperfusion syndrome.
Right, thank you.
I give one point. I just want to explain one more thing, and which is very important for all of us. When we look at the CT scans, there's one concept for all the cardiac surgeons. It's you have to identify the malperfusion. It's dynamic or static. If the SMA is dissected, thrombosed, there's no flow at all. No matter what we do here in central aorta, we cannot open that branch. If it's just dynamic, the flap covers the orifice of the SMA or celiac or renal arteries or iliac arteries. We do central repair, introduce children into the blood into the children, we can resolve with the stent graft frozen trunk or not. We can resolve that dynamic obstruction. That will resolve malperfusion. So if you see a CT scan, it is a static malperfusion. You need to be very cautious. Patient may have no symptoms because of collaterals. If patient has severe abdominal pain, like this going up, I think the best way probably is to resolve that dynamic, that static obstruction of SMA first before you embark the big open operation.
So I'll ask the next question. This one's to Dr. Bavaria. What has been the institutional practices and preferences at University of Pennsylvania as it pertains to patient selection? I remember prior to the formal start of this meeting, you may have mentioned an elderly patient and how you were managing that. I wanted to get your perspective.
Yeah, well, I think we would be a little bit different here. We very rarely use a non-central first approach. Maybe on an occasional high lactate SMA situation. I totally agree with Bo's point about static and dynamic obstruction. And that's a really, really important point. The fact of the matter is, though, is that basically all dynamic obstruction of any type really needs a central repair. And I think today, and in the next 5 to 10 years, this is a little bit of an old style kind of approach, in my opinion. We're going to be going to doing these operations, in a hybrid operating room. We do these routinely now in hybrid operating rooms, and we have all of the available devices for kind of immediate application. And so there's a revolution going on in the treatment of type A dissection, which is basically a continuation of the arc of history for type A dissection repair in general, going from straight cross clamping to ubiquitous use of an open arch technique, and then to using a little bit more adjunctive procedures such as antegrade stenting in the era prior to frozen elephant trunks. And then using Thoraflex or frozen elephant trunks for certain cases, and now even placing, doing say for example zone 2 arches, and then doing sequential placement of stents as needed. I think the bottom line here, for me anyway, is that we need to kind of go towards techniques which recognize the fundamental concept. The fundamental concept has been recognized for 30 or 40, even 50 years, which is that type A aortic dissection, especially DeBakey 1 dissection, is a total and complete aortic catastrophe. Okay, and it needs to be thought of about like that. And the only reason why this was not attacked in that fashion in previous history is that they simply couldn't do it and get a patient alive at the end of the day. But we are getting better and better as a community, and my personal opinion is we need to do operations that can say valve spare or do something decent at the root. We need to attack the arch with a little bit more gusto, and start doing either super aggressive hemis or zone 2s in our practice, which is the most common operation we do. And then we need to kind of think about the distal aorta either early, super early if you've got a malperfusion going on, or in the kind of the mid phase, subacute phase, to try to modify the natural history of this disease late. So I think those are the big concepts. I think that we can medically manage these patients, but as I said earlier, we just medically managed a patient, but she was 87 who ruptured on day 3, and we tend to recognize, and this is true from taking lessons from the type B dissection history and treatment, as well as type A dissection with proximal repair, that about 70 to 80% of all distal perfusion problems will go away immediately with restoration of proximal flow through a normal channel. So that's kind of my approach. We do this maybe once or twice a year, which is to do a secondary procedure first in an SMA malperfusion, but usually we just go straight to the operating room. We've gone to central cannulation now for everybody, which is really nice because you put a cannula right into the proximal descending aorta, the true lumen, which actually kind of stents open the true lumen immediately, and instead of doing femoral or axillary cannulation like we used to.
Joe, what's the timing for your, so if most of your type A's with malperfusion are having proximal repair and a zone 2 arch, what's your timing for TVAR afterwards?
Well, if they have a bad malperfusion, you know, we would probably put in a frozen elephant trunk at that point. Mm-hmm. So our algorithm really is kind of a threefold algorithm. If you have less than a 10 or so life expectancy, we just do a standard ascending hemi and get out of Dodge. If you have a fairly significant distal malperfusion, we tend to do frozen elephant trunks. Presently, it's an antegrade stent, but as soon as we get Thoraflex, it'll be a Thoraflex. And that represents maybe 10–15% of the population. And then the rest of them, we tend to do zone 2 arches on almost everybody. And we'll come in and do a sequential, you know, we're using the TBE grafts because we have access to it, which is a beautiful thing. So that way we can just plug it right into the subclavian and then push it down. And then, you know, that's kind of GREEP network friendly in the sense that you've got between 2 weeks and 8 weeks between them, so that the collateral network theory is alive and well, and we have 0 paraplegias using that kind of technique. And that way we kind of think it's a conceptual thing. We think that a DeBakey 1 dissection is a total aortic catastrophe in all domains. So by treating this, we're hopefully going to be modifying the natural history quite substantially.
Thank you, Dr. Bavaria. Just following up on your cannulation strategy, central cannulation, Dr. Ouzounian, I had a question for you and Dr. Girardi. What strategy do you use in Toronto, and what are your thoughts on central versus femoral or axillary cannulation for these patients? And what is your thought process behind that?
Len, do you want to go first?
No, go ahead, Maral.
Okay, so for cannulation, if the nominate artery is not dissected, it's my preferred place. I put a graft on it without opening the pericardium. So I just dissect it out above the nominate vein, put a side biting clamp, give heparin, put a 8mm graft on it. That's your ACP, that's your flow for the pump, that's everything. It's really easy. I do like axillary cannulation still, but I must say I've gone more and more to central aortic cannulation with a Seldinger needle. You have to look at the CT scan very carefully. If it's one where, you know, the whole true lumen's like completely off intussuscepted and there's like very little true lumen there, if it's completely shredded, it's not great for central cannulation. So CT scan and TE guidance is obviously key for that. But it's a very fast way to get on pump for sure. So we are using more of that. But until now, it's been innominate and axillary are my preferred.
You know, we have used central cannulation as well. I would say 95+% of the time. And we use handheld epi-aortic echo as well as TDE to confirm true lumen cannulation. It's very reliable. And as Joe said, it allows you to open up the true lumen pretty rapidly, particularly for these people with malperfusion. So we like it, and especially for the patients who are, you know, you get someone who's got a BMI that's pretty high. It's tough to do almost anything else except for maybe an nominate. You can spend a lot of time trying to find the axillary artery, and certainly the femoral is less desirable in that setting than in others. So I think central is the way to go. It's rapid, it's reliable, and it's pretty easy.
Thank you.
Better, faster, safer.
Other than that.
With big tears, is it still, I mean, with big tears in the arch, I've shied away from it. Just, I guess you can keep trying to see where the wire goes and go. Do you just still go central with a arch that's really shredded up? If the tear is in the arch.
I haven't, I mean, knock on wood, I've been lucky, I guess. I haven't had too many problems. I think I try to gauge where I'm going to actually access the true lumen based on the arch anatomy. So I may change how far out on the arch or how far out on the lesser curve I go to try to stab it and find it. But knock on wood, even with a pretty bad arch problem, usually be able to find it. And then you can just slide the wire around into the descending and actually slide the cannula itself into the descending. And it works pretty well. So maybe I just don't, maybe I've just been lucky. So
that's great.
Yeah, one thing I know for the cannulation about the central cannulation, and we use here too. And I do not use often, and I use all the arch branch vessels, including subclavian artery. Actually, I just want sternotomy or subclavian artery, enumerated artery. If enumerated artery is not dissected, use enumerated artery. If it is dissected, I just dissected the distal and the subclavian artery, or carotid artery, each side. Any vessel is I use from the arch, because just set up for ACP very quickly. One thing about the, I think the advantage of that, if patient come in with dissected carotid artery, completely occluded thrombosed carotid artery, if we do central cannulation, there's still no flow to the brain. So I just cut down to the carotid, cannulate the carotid artery, and kind of retrograde. If you can perfuse into the aorta, perfuse the whole body, I use one cannula. If you cannot, I put the femoral and perfuse the lower body. So I really needed to do that. Actually, even carotid is like dissected thrombosity. And then you find the distal is not dissected, and retrograde perfuse that direction. And because it's from the true lumen to true lumen, and that works pretty well. So I like the arch branch vessel cannulation is because it just set up the circle rest very quickly. I just did a clamp, denominator artery and carotid artery, and I do an ACP very quickly. So then do you cannulate the arch vessel for the ACP? How do you do ACP, or do you do RCP when you use the aortic cannulation? Just RCP.
Yeah. I don't touch the great vessels for a type A at all. I try to stay away from that.
Because they're dissected? Because they're dissected?
Yeah, and I'll go up as high as I need to, even into the neck, as you were talking about, to get away from the dissected vessels. Yeah. So I try my best not to manipulate them with snares or clamps or catheters or anything. Just try to stay away.
I do. I'm a little bit, I'm a little bit more, I don't know, how's the right word? It depends on which kind of arch operation I'm doing. So I tend to do RCP for as well for all hemiarches or open distals. It's fast and it's so simple, and it's no touch, and it's great. And we don't have any problems because we're always below 30 minutes of circ arrest, and we're relatively cold at 20 degrees centigrade. But I do antegrade for all zone 2 arches, which is our preferred operation. But I retrograde for 5, 6, 7 minutes, and then cut out the aorta, cut out the arch, make sure everything's perfect, and then we'll introduce direct cannulas into the left carotid and/or innominate for either unilateral, bilateral. I try to do bilateral unless the arteries are terrible. And then if they're both really terrible, then we'll just stay on retrograde and like Len does. And occasionally you have to do that. But we tend to do antegrade for branched arch, work. So
what's your favorite cannula for the direct ACP through the innominate or the carotid? Do you have a favorite one?
Yeah, I use the DLP retrograde cannulas 13. They tend to be, and I have a pressure transducer on the left carotid, so I run my ACP to a left carotid pressure of 60. As Randy Greeps told us a long time ago, there's no autoregulation in the brain at 20 to 24 degrees centigrade, so you just have to flow at that kind of pressure. You actually don't want to flow too high because the results are actually worse. So I flow to a pressure of 60 and make sure my NIRS, which is on every patient, is great bilaterally, and feel pretty good about that. The problem is you don't want to blow up those balloons too tight and end up really messing up with these arteries. So you got to be a little bit careful with these. But at least everything's antegrade, you know. I mean, that's the reason why I like central cannulation so much, is that everything is antegrade and in the true lumen. And even if you axillary cannulate and you've got a dissection in your innominate, you know, you're really flowing retrograde in all of your brain cerebral vessels, and that can really mess things up. So I've really gotten away from axillary cannulation. I used to, you know, do it a lot, 500 times, you know, but now we almost never do it except in a redo.
Yeah, it's handy in a redo for sure. And you're at 24. I go to 24. I don't know what temperature, just in case you have to do the whole arch. And I give ACP for sure, basically almost every time. Yeah.
And how cold do you go when you use RCP?
20.
20. Yeah, we pretty much stop at 28 for I use unilateral ACP 28 pretty much most of the arch work, including total arch.
I'm kind of with Len. I usually go to 20, no matter what. On a type A bad, you know, DeBakey 1, we'll go to 20 on everybody. You just never know. Also, you know, you got to do some proximal work, so it doesn't really matter. You know, the total cardiopulmonary bypass time is really the time to cool and the time to rewarm and the time to do the arch. It doesn't make any difference. You know, if you're at 28, you're just going to be sitting there while you do the proximal work. If you're doing a D5 or a root.
Well, let me ask you a question though. At 28, right? When you look at a broad literature on mild hypothermia, and this could be mild, moderate, I guess at 28, depending on who you read. But I've been concerned about the results, not so much of brain outcomes, because the brain protection when you're given antegrade is pretty good. But I'm really not happy with what I see for distal organ protection at 28 for longer periods of circulatory arrest. I mean, there are some pretty high rates of renal replacement therapy needs, hepatic dysfunction, gut ischemia, et cetera, and even increased spinal cord risk. I really get worried about that at 28. As Joe said, if you're not, you know, you don't always have a really good way to know everything you might need to do in there. And the next thing you know, you got a 60-minute, 70-minute circ arrest period, and you're at 28 for your distal organs. Do you have any concerns about that?
Yeah, that's a very valid question. What we always thinking about, and we focus on brain first, but since we have ACP, so the brain actually is well protected. So then distal, worry about spinal cord, but based on the research from Mount Sinai, 28, spinal cord can tolerate an hour or a little longer. And we most time from our data, you know, the distal circ arrest time, you saw either hemi-arch or zone 1, 2, 3 arch, we saw that most times it's less than 30 minutes. And our renal failure or other, because we resolve malperfusion first. So, and we do not see any a change or increase high incidence of renal failure and the other complications. But I do agree with you. If you get too long, like 60 minutes, that's yeah. I think you should go colder. And if you anticipate a lot of arch work to do, I remember I did not type A dissection, my cardiac arch, huge abscess. I anticipate I probably spend an hour and a half or 2 hours to debride that myocardic aneurysm. So I didn't go cold either, but I was able to put a intra-aortic balloon into the distal aorta, not dissection the distal aorta, and the distal perfuse the organ all protected. So I don't need to cold either. So, but yeah, that's a very valid concern, and I agree with you on that.
Yeah, I'm with Len on that one. I think when you're thinking about temperatures, for sure, especially as a trainee and in the early years of your practice, hypothermia is your friend, 100%. And especially, we don't worry as much about the brain if they have bilateral ACP most of the time, but it's the spinal cord, the kidneys, the bowel. And there are ways to give distal aortic perfusion as well, or just go cold. I think, especially if you have no idea how long you're going to be, it's better to have some safety there.
Yeah.
Good advice.
I have a question for any of the expert panel to take this. Given the complexity of open aortic repair in the setting of a patient with a previous cardiac surgery, but also with malperfusion syndrome, I know this is not a large cohort, but in that setting, what would be the perspectives of your individual practice in a TVAR first method?
For someone who's had previous open heart surgery?
Previous open heart surgery and also has a type A dissection.
Well, I can start. Go ahead, Joe.
No, go ahead, Len. Or Bo, whoever's going to do it.
Okay, and actually, we did publish another study, just the patient with previous cardiac surgery with malperfusion, and we did the exact same approach. And the previous cardiac surgery does offer some protection, but it's not fully proof they can still rupture. Based on our experience doing this, the medical management with malperfusion, treating malperfusion first, we did in the early stage, we did have patient ruptured. But anybody coming with malperfusion syndrome, and they no matter had previous surgery, and we have the same approach, endovascular, resolve the malperfusion first. Then when they're better and organ function better, you do a redo, which is probably more difficult than the virgin chest type A dissection. You look at the literature, the mortality of a redo type A dissection is, I think it's about 20 to 30%.
Joe, what were you going to say?
No, I mean, I don't. If you have a type A dissection, and you have it's a redo, you're just going to have to, as Bo said, there's a little bit of protection against rupture, but that's about it. And I would, kind of move along and get the case done. And I don't think it really plays that much of a role in your decision making regarding TVAR first versus not doing TVAR. So that's, I suppose that's my answer.
The redo with previous grafts, I think that's, to me, one of the highest risk groups of patients who are reoperations. I mean, it's really sets up a whole different set of problems that you wouldn't have if it were just a valve or even a previous Bentall or something like that. And those are the patients that I get most concerned about, and certainly give me the most concern as far as what am I going to do with myocardial protection? What am I going to do with revascularization? What am I going to do when I have ischemia coming off? I think it complicates matters dramatically. Those are about the only patients that if I have time and they don't have a malperfusion syndrome, if I can, I'll cath those people.
Yep.
And that's about the only group that I'll cath before going to the OR. But if I can, I will, because it's helpful. And anything that gives you more information that can save you time, can help with your protection, I think you're going to end up with a better result. So I would take advantage of perhaps just a smidgen less rupture risk in those patients and get them to the cath lab if they're stable.
Our cath lab probably cardiologist kind of cautious or not that happy to do the cath for those patients. So, and our practice, we do not cath those patients. And most of the time I just review the CT scan to see if the graft's patent or not. And if I give a retrograde, nothing comes out, and then the CT scan, you can see thrombose, I don't reimplant them. If they're patent on the CT scan and retrograde coming back, I reimplant them. So we do not do the routine cath for those patients.
Great, this is a perfect transition to the next paper that Dr. Bavaria is a senior, and I think he alluded to this approach of central repair first with concomitant antegrade TVAR for malperfusion syndromes in type 1 aortic dissection. So this was a study that they utilized 277 patients from 2005 when the practice change initially started to 2012, and included about 104 patients who had end organ malperfusion. And they divided the cohort into the standard group versus the group that also received an antegrade TVAR during their procedure. So as far as demographics and preoperative comorbidities, they were much similar. but circulatory arrest and cross-clamp times were much more significantly longer in the TVAR group. And overall, post-operative stroke rates, paraplegia rate, and renal failure rate were similar between the groups. And also in hospital mortality was clinically lower in the TVAR group, but did not reach statistical significance, likely because of the volumes that were there. But then, since the majority of the patients had multi-organ malperfusion, they ended up doing a subgroup analysis that looked at their outcomes. And there was actually some interest outcomes there. So in patients presenting with malperfusion involving the greater than one end organ system, the mortality rate was significantly improved with the TVAR group. And there was an absolute risk reduction of almost 30% in that cohort. In the long run, the TVAR patients appeared to have improved survival compared to the standard group, especially for this specific subset. So Dr. Bavaria, as a senior author and something that your group has published, my question to you is, I know you alluded to the different techniques that your group has been utilizing. Have you seen improvement in these outcomes, and with an updated series, have you seen improvements in general with the learning curve associated with this approach? Or are you sort of shifting depending on the surgeon preference at the time?
Yeah, this is all about the kind of as I said, the history of how we approach these cases. So, this was initially done, we actually did this at the very beginning of the, right when the Gore graft came out and was approved in March of 2005. And we did it because we had the first patient was just a massive SMA malperfusion, just like Bo was talking about. We didn't really know what to do. And we had this new thing, and we just decided to put this antegrade T-bar down, and it worked. So I suppose we started doing these cases mostly for malperfusion, but also initially in a series for remodeling purposes as well. We were just experimenting basically, and but then we kind of chucked the remodeling stuff and just mostly did all this mostly for malperfusion. Kind of like Joe Caselli's paper, which was a very, very similar paper a little bit later, which was mostly for a malperfusion indication. And so we still use this for malperfusion only at this stage, but we're doing less of them because the zone 2 arch or more of a robust arch operation tends to be pretty adequate for a lot of malperfusion issues and makes it it's a better operation for that. So we do these for really pretty nasty malperfusions. We're down to about I'd say only 10% of our cases get antegrade stenting, and it's a fairly robust and legit malperfusion indication. We will do a Thoraflex for this in the future. Maybe Maral can talk about this because she has access to those. The only access I had was during the US IDE trial. And I know that's probably one of the main uses of Thoraflex in Europe for type A dissection indication is when there's a significant malperfusion distally. So that's kind of the evolution of our practice regarding this adjunct.
Are you using, or for the Gore, it's a 10 centimeter stent you use, Joe?
When we do antegrade stenting?
Yeah,
10. Sometimes we use a 15 in a male, especially if we're going from zone 2. Yeah, usually a 10, occasionally a 15.
Mm-hmm. But your zone 2 arch really, it leaves the option for all of that later, which is the nice part of it. We use Thoraflex in an acute type A dissection for malperfusion indication, but you have to be, we want you to have, we think you have a reasonable life expectancy. Okay, I'm not putting a Thoraflex in an 80-year-old, even if they have malperfusion, they're getting an uncovered, they're getting an AMDS stent, which has 0 spinal cord risk like 0, and it's a lot easier of an operation. But if you have an arch tear, the thoraflex, the beauty of it is it's also super hemostatic. So because the descending aorta is stented and you have the skirt where you're doing the distal anastomosis, we do it with, you know, circumferential row of valve pledgets through the skirt, core knot the valve pledgets down, and then run a really tight other circumferential, you know, foro layer over that. So it's a very, very hemostatic distal anastomosis in the setting of type A dissection. There's no false lumen pressurization after that. The whole arch is done, but you have to be, you know, fairly young with good life expectancy for us to do that for you in an acute type A.
Thank you, Dr. Ouzounian. So I have a question for everyone. In a young patient with DeBakey type 1, type A dissection, when do you consider just a hemi-arch replacement versus addressing the total aorta during the index admission or the index procedure of the same admission? When do you opt for either strategy? Dr. Bavaria?
Well, we've totally changed on this. We have a younger patient. If it's a Marfan's patient, that's the only indication right now that I do a total arch on, or Loeys Dietz. But everybody else, if they're stable and they're young, for the most, not everybody, but most of the time, we do a zone 2 arch on all those patients. And we'll come in with a TBE graft, which is a new a single branched arch graft, usually between 2 weeks and 10 weeks, when we still have the ability to have apposition of the true and false lumen in the descending aorta. And the results have been really, to be honest with you, they've been incredible. Because it's a simple operation at the index procedure, they get over the operation, and then you get to them regarding their residual aorta at a time when it can still be treated as an kind of an acute dissection. We're not in the total chronic phase. So we're totally enamored with this operation, which is a design of an operation based on the availability of new technology. So that's kind of where we're at with that patient.
And the Marfan patient, so big root, DeBakey 1, Marfan, they're getting a total arch, even if the arch is not dilated. And is it a classical total arch? Is there an elephant trunk there, or how's that arch done?
You're talking to me?
Yeah, Joe.
Yeah.
You said every Marfan gets one, so
yeah.
I'm not that aggressive, because usually it's the Marfan Loeys Dietz who are getting a valve sparing, and already now my clamp times, my clamp time's getting up there.
Yeah, good point. But they're young and they can take it. The we'll do either a zone 2 arch with a completion subclavian, or else a standard zone 3. That is the one case where, in the chronic phase, that's the one case I actually do a classic elephant trunk on, because I'm going to do an open TSRA later on, and not a. I'd rather sew into a classic elephant trunk than a frozen elephant trunk when I'm doing a distal TSRA. Len probably has more experience with that than almost anybody in the world. But that's kind of how we do it. We're not really throwing down in the acute type A dissection situation classic elephant trunks, to be honest with you.
Mm-hmm. Len, what do you do in the Marfan Loeys Dietz big root DeBakey 1 arch is dissected but not enlarged?
I think you're muted.
Sorry about that. I try to stick to a zone 2. I think if the arch is dilated, then I'll go out and do a zone 3. But I really try to stick to a 2, because you can always figure out something to do with the subclavian at a later date and establish yourself a good landing zone, as Joe has described in so many different ways. You can make it the landing zone for yourself and make life easy for later on. We really don't do a lot of classic elephant trunks for the acute type A's. As you know, that distal descending aortic suture line is really hostile. And also the aortas are, for the most part, pretty small, and stuffing a trunk down there is not easy and can be hazardous.
Yeah.
So I really try to avoid that unless I see that the distal aorta is also fairly sizable, in which case then you have a lot of space and it's okay. But a lot of these little, like you were saying, Maral, the normal size aortic arch, it's not easy at all. There's no room in there. It takes a long time.
Yeah, I think the classic elephant trunk in the setting of acute type A dissection is really kind of gone the way of the dodo. You're losing all the benefit of expanding the true lumen distally with some kind of stented, uncovered or covered stent. So, and it's usually small, more trouble than it's worth to try to stuff some dacron into the true lumen. I think that whole, unless you have a large thoracope, mega aorta and you need a thoracope abdominal and you're planning that, then that's different if you have a lot of space there, but that's very rare in the acute dissection setting. It's very rare.
I got to tell you, Len's onto something. The zone 2, and obviously, we've been doing this for a while now. The zone 2 arch, this is for all of the residents out there. The zone 2 arch is an operation you got to learn how to do. It's actually a beautiful procedure, and you can play with it in multiple levels. You can create yourself a nice zone 2 LZ, or you don't have to. But here's the kicker: from a dissection standpoint, about 40% of the time, maybe Len and Maral can corroborate this or not, but 40% of the time you're going to end up having very significant intrathoracic remodeling just by the mere fact of doing a zone 2 operation. So I'm always kind of stunned at how beautiful a lot of the descent aorta looks like even after an index zone 2. And so you're not going to need, in 40% of the cases, you don't even need to do anything distally, even if you were originally planning on doing so, because it's kind of auto takes care of itself.
Yeah, so, one thing I want to add is don't treat the Marfan's and low EC the same. Low EC is a lot more malignant. It's TGF-beta receptor 1, receptor 2 mutation. It's a lot more malignant, aggressive than Marfan's. Based on the study from Japanese group that follows patient about 20 years, and they find the Marfan's need the redo arch much less and insignificant. Those Ds that need the redo arch upper type is much higher. Yeah. And for low Ds, I will be more aggressive. Zone 2 and those 3 arch, I would recommend that in type A dissection, or even in prophylactic and valve-sparing routes, just on the root aneurysm. Marfan's, I do not go that aggressive. And so that keep that in mind. They're not the same disease, even though they're all connective tissue disease. And I haven't put any traditional elephant trunk into the acute type A dissection. I really don't see a application of that. I think frozen elephant trunk has a advantage of that. That's very important. I mean, the criteria I use for aortic arch replacement. Number one, there's a tear in the arch. I have to resect that tear. If I can do a hemi-arch, resect that tear, I do a hemi-aggressive transverse arch. I do that, 80% cut the arch out. If I can't, I do more aggressive, zone 1, 2, 3 arch. That's number one goal. Number two, if there's aneurysm there, I cannot cut it out with a hemi-arch or transverse or a partial arch. I do more aggressive, zone 1 arch, 1, 2, 3. And another thing is about the progression of the distal aorta after different arch replacement. And we are just writing abstracts right now. We have aortic dissecting database. We follow patients about 20 years. We study all the CT scans, and we divide the patient into hemi-arch, zone 1, 2, 3 arch, and different operations, and see how the arch descending abdominal aorta progress. Based on our criteria, we use resect the tear in the arch, resect aneurysm. If there's a malperfusion, we do more arch replacement, reimplant the head vessels. We do not see difference of the progression of the distal aorta between those 3 or 4 treatments: hemi-arch, zone 1, zone 2, and those 3 arch. So yeah, normally I don't put the frozen elephant trunk in the patient unless I see a tear in the distal, in the descending thoracic aorta. I try to cover that. And all patients have really a narrow room for dynamic malperfusion. I put a stent graft there, opened it up, helped the prevent the dynamic malperfusion.
I think, we're actually addressing this question with a randomized trial called Head Start that is taking all comers with a DeBakey type 1 dissection where the surgeon thinks they could have either operation, a hemiarch or an extended arch, and they're randomized to hemiarch or the extended arch repair technique of the surgeon's choice. But it includes some sort of stent in the descending thoracic aorta. So we're just getting that trial up and running. I think it'll provide a lot of information, just even with the imaging data, to prospectively look at a randomized group of patients to see what happens both on the imaging side and on malperfusion resolution.
Thank you, Dr. Ouzounian. We're looking forward to the results of the trial. Just a follow-up question based on the points that were raised regarding Marfan. When do you consider root replacement in type A dissection? Does Marfan or other hereditary diseases play a role in this, or the position of the primary intimal tear? What are your thoughts on that, please? Maybe anyone?
I think if you have somebody, go ahead, Joe.
So this is pretty straightforward for me. If you have a younger patient, and you're talking about Marfan's, right, Irbaz?
Yeah.
Those patients, first of all, they should all get roots. Period. Number two. So the next question is, do they get a root, a Bental operation, or do they get a valve sparing operation? And when you go in there and you look at the valve leaflets, and the leaflets are fine, you should valve spare all those patients. It's kind of that simple, and just that's kind of my opinion. Now, in the older days, I would root all those patients and not do a valve sparing. But in the last 10 years, we've done a valve sparing operation in almost all those patients. And they do pretty well. If there's a problem into the coronaries or some reason not to do a D5, then we would just do a regular Bental operation.
I would agree with Joe in that we would be very aggressive in the root on somebody we assumed would have a connective tissue disorder. I'd say the only caveat to that being is that, for a lot of residents who are going into practice, if you're not doing it all the time, a Bental is going to be much more reliable. And I think there are some nuances to valve sparing, particularly for connective tissue patients, that are going to eat up a lot of time. So if you're at a place where you're doing it all the time, no problem. I would agree with Joe 100%. That a lot of these people, the valve looks really good. You get rid of all the native tissue. It's a very hemostatic operation, and pretty much the valve's going to work almost every time. But if you're not doing root stuff all the time, and if the patient's a little shocky and you're a little nervous, you don't have a lot of help, it's 2 o'clock in the morning, there's nothing wrong with a Bental.
Absolutely. Put in a St. Jude or an Onyx Bental and go for it.
Yeah, 100%. I think especially with a sick patient, if you're not doing valve sparings electively, then doing it in the middle of the night, adding your clamp time and a potentially reclamping for AI situation is just not, I don't think it's realistic. You should be doing them regularly on an elective basis to do them in acute type A's. And in the patient, for sure, the connective tissue patient, they're coming with a root problem. That's where their pathology starts. They need a root replacement. But for the older patient, with the ascending enlargement or type A, most of the time you can resuspend the valve, make some neo media of whatever of your choice, resuspend the valve and do the repair at the STJ without replacing the root. And if you look at all of the type A literature, it's 70% of the time the root is not replaced. It's reconstructed, the non-coronary, usually the dissection goes into the non-coronary sinus, maybe partially into the right. Those can be generally reconstructed. If there's a root aneurysm or the tear is in the root or your coronaries are shredded, or all 3 sinuses are dissected, these patients just go ahead and replace the root for sure. But often you can get away with not.
I agree with that 100%. That's a little bit of a difference. There's kind of a transatlantic rift there For some reason, I'm not quite sure I understand. Every time I talk to Europeans, they're doing a lot of routes for reasons that I'm not quite sure that I understand. We should be sparing these valves with good root techniques, as Maral just said, in most of these cases, and just sewing at the STJ and having a nice robust root reconstruction into the non-coronary sinus, or doing what I call a hemi Yakub, or kind of a 1/3 Yakub if you want to get down into the non-coronary sinus. But those are all operations that spare the valve in a kind of a regular dissection case, and they work well, and you don't necessarily need to take the valve out.
Yeah, back to your question, it is an easy decision if it's Marfan's patient, right? You know he's Marfan's, his root is abnormal, you need to take the root out, either valve, spring, or ventral. Patient with a known gene mutation, such as anything, OSDs or TGB mutation, SMART3 mutation, those all have root aneurysm. We'll need the root operation in the future. We need to take care of the root at that time. The question is, when patients come in, you do not know. You do not know he has what mutation he has. And should we take the root or not? The root is not that big. All right, how do we decide? We sequenced all our dissection patients, all patients with aortic dissection. We found out patients with pathogenic mutations, including fibrin-1, TGB pathway mutation, and the collagen mutation, OS mutations. Those patients are younger than 55, have family history, and do not have high blood pressure. Those are the risk factors. You look at the patient at night, coming young and no family history with dissection, no hypertension, suddenly come here with a dissection, and the root is marginal. I think that root needs to go. We did that study. We compared the patient with the pathogenic mutation and the non-pathogenic mutation. Eventually, all the patients with pathogenic mutation or high risk to have pathogenic mutation had a root reoperation later because the type A dissection didn't take care of the root pathology. So those patients, the Marfan's for sure. OSD, the connectivity is for sure. Patients with high risk suspicion, high suspicions, younger than 55, no history of hypertension, family history of aortic dissection aneurysm. We need to take care of the root. Otherwise, patient will come back with the root operation, redo.
So that's great discussion so far. I've probably one of the last questions. Fellowships, especially for trainees looking into specializing or considering aortic surgery. What are your thoughts individually about fellowships, whether they should be or not? And I'm sure it's different in the US and Canada. So how different it is, how similar is it?
I'll jump in there. I have strong opinions on this one. I mean, aortic surgery has become a niche, skill set. It's hard to be a high-level aortic surgeon and do both open, endovascular, valve-sparing root, total arches, frozen elephant trunk, thoracoabdominals. It's to really be an aortic expert, I think takes dedicated training. I'm biased because I spent a year doing that with Joe Caselli in Houston. But I would go to Len, I would go to Joe. I'd go anywhere with a formal aortic program. And in Canada, we, all of our I6, almost everybody, all of our I6 residents do a year of some kind of niche fellowship. And it's because, there's only 30 centers in the country. When we're recruiting our new faculty, we want them to have a clinical area of expertise. So you're coming in, you're going to do mini mitrals for me, or you're going to do VADs, or you're going to do aortas. You need to be an expert in that area. And I think to get that expertise, you need to be in a high volume place where you're seeing, aortas every day. And, my year in Houston was phenomenal. Every single day, Joe's list was, third time redo frozen elephant trunk in one room, the other room with thoracoabdominal, the third room was T-bar and TAVI, every single day. And so if you have that kind of volume, the amount of knowledge you acquire in that year really carries you. And then when you start your faculty position, You know, my first case was a 27-year-old 11-centimeter ruptured extent 1 thoracoabdominal who had Marfan's and had a previous mechanical Bentall. So I would have had no credibility doing that case if I didn't have that dedicated experience. But because I came as an aortic surgeon, there's a bit more latitude. You know, your senior surgeons can support you getting complex cases done in your early career, but you have the credibility as an expert to take bigger cases on than you normally would as a junior faculty.
Well, I would only add, I couldn't say it better than Maral just did. And she's younger, so she has a little bit more cred with the group that's on this line. On the other hand, I would like to say one thing, and that is every cardiac surgeon needs to know how to do a type A dissection. You are, you know, I don't think you can consider yourself a cardiac surgeon unless you can do a type A dissection. It's one of those kind of index procedures. You know, I always say you got to learn how to do a redo, you got to learn how to do a type A dissection, you got to learn how to do a mitral cabbage, because those are the 3 hardest cases in cardiac surgery. So, because, you know, the facts is that type A dissections are fairly acute, and some of these patients are simply not going to be able to travel and not be able to get on a helicopter or an ambulance, and you've got to be able to do them. And then even if it's just a regular hemiarch, ascending hemiarch, and then you send them to Maral or an aortic surgeon, you know, a year or 2 or 3 years later when they need kind of a complex redo surgery. So that's, I would only say, I agree with Maral 100%, obviously, but I do think every heart surgeon on this line needs to know how to do a type A dissection.
Great.
You know, I came from a little bit different from Maral, and I didn't do aortic fellowship. My experience is, if during your cardiac CT surgery fellowship, you had a very good experience with aortic surgery, and you go to a program, there are aortic surgeons, you know, there are your team, 2 or 3, and you're the junior aortic surgeon there. You are not the one to build up the aortic program. And with your own experience and the experience, the expertise of your group, I think you can grow as a junior faculty attending and become like very specialized expert in this field. And it all depends on how much you have learned, how much you're comfortable with the aortic surgery during your regular CT fellowship and what you're going through and what situation you're getting into.
Mm-hmm. Bo, that's great. And, you know, the Michigan group has a strong, very strong aortic team. But if you're starting a program somewhere or going somewhere without that senior level support, then having some dedicated training. Also on the endovascular side, you know, the endo aortic world is really changed a lot. And, you know, all of these custom made, you know, 4-vessel fenestrated arch grafts, thoracoabdominal grafts, and so on. If you want to do any kind of high level endo work, then it needs some training for sure.
No, I think all these points are great points, and there's a lot of different ways to get good training. And if you're fortunate to be an ACGME fellow in a program with a very strong background, like Penn or others, where you have a lot of surgeons and you have a lot of patients, you can get enough experience in those 2 years to do the fundamentals. I still think an additional year of sort of complex aortic work, sort of like Maral's describing, particularly if there's an endovascular component to it, you're going to need a little extra time to become an expert in that and to have that credibility to be doing those kind of cases from the get-go. But I do think Joe's point is a very good one, at least for me, as a take-home message, and that you got to be able to do it type A. And you don't have to do, you know, the blue plate special. Just get in there, get a tube graft in. You can leave the root, you can leave the arch, and send it to somebody else a year later. Your job is to get a survivor, and you can do that pretty well with the fundamentals that you learn in your 2 years or 3 years or your I6. And that's a skill you just got to have.
Yeah, super important. The volume of type A's per center and per surgeon in the US, you know, apart from the high volume centers, is very, very low. So you want the patient alive. An elective redo root or total arch, that you send to the aortic guy, and, you know, we can get that done safely on an elective basis for sure. But the goal with your type A is to get the patient home. Yeah. Good take home message.
Absolutely. Well, I thank you guys so much. I would like to thank our panel for being here this evening. We can tell that all four of you have a late evening currently in your offices. I thank you guys for helping us guide this discussion. There are a lot of learning teaching points that the residents have. I'd like to thank Medtronic for giving us this unrestricted educational grant to have this discussion. And on behalf of the TSRA, thank you. And, good night to everybody.
Thank you to the TSRA.
Thanks for having us.
Great job.
Thank you very much.
All right.
Bye.